So now it gives me great pleasure to introduce Jeremiah Weinstock, who is a licensed clinical psychologist, professor of psychology, and the chair of the psychology department at St. Louis University. Dr. Weinstock has authored over 65 studies. His clinical and research efforts center on addressing the difficulties in helping individuals with addictions make lasting and meaningful changes in their lives. But more specifically, he focuses on the characteristic and treatment of gambling disorder. Much of his research is translational, meaning he takes fundamental knowledge and determines effective applications. He also maintains a small clinical practice focused on gambling disorder. And my first introduction to Jeremiah was at the ICRG conference. We use a lot of acronyms, where I heard him present. And Jeremiah is a sought-after speaker, and I'm pleased we were able to get him to come to Minnesota. Suicide is a difficult topic on so many levels, and I think you'll find his presentation informative, practical, and accessible. And so please join me in welcoming Dr. Jeremiah Weinstock. Thanks. You got your hands full there.
A couple things over here. Here. All right, let's put this down here. All right, I have my. Turn me on. All right. I got my water here, my caffeine here. So, and the clicker is this guy. Big green button. That button. Oh, that's big. All right. Welcome everybody. Before I get started, I actually just want to take a moment. Unfortunately, Randy left, but he was very influential in my career. One of my very first research projects was basically inspired by a study he had published and got me kind of launched and interested in this area as a researcher. And so, unfortunately, he's gone, but I just wanted to pay a moment of respect to Randy because he's such an influential figure in our field, and it's wonderful that you guys acknowledged him. All right, so I'm going to be talking about gambling and suicide. This is a very heavy topic. We're getting started on a very important topic, though, and I just want to take a moment to acknowledge that some of you may have some contact with suicide in your personal life or in your professional life. I also want to acknowledge I'm going to be talking for 2 hours, so you may need to get up, stretch your feet, move to the back of the room. You may even need a restroom break, and that is totally acceptable and fine, and I won't have the narrative in my head that I'm terrible and that you're just leaving. So please just take care of yourself during this time, because it's a really important topic, but it's also a heavy topic, but impactful. So I just want to acknowledge that before we get started. All right, so I always like to start off with a quote, and it's from an English author, and he just says, gambling is a way of buying hope on credit, right? What I actually, as a clinician, one of the things I like to tell my clients very early on is that my job is to take away hope. My job is to take away hope that gambling is ever going to solve your problems, right? My job is also to instill hope for a better future, right? And so that is what we're talking about here today with suicide, is many individuals do not see a path forward except for taking their own life. And so our job is still to instill hope for a better future, that their circumstances can change and things can improve in their lives, all right? So we are in the business of hope. As your helpline had that phone number, hope in it, it's a really important concept in our work. All right, so learning objectives. First, I'm going to talk to you about the important demographic and clinical characteristics that are associated with suicidal ideation, attempts, and suicide, and how that is just a big overlap with the clinical characteristics of what we know with people who struggle with gambling disorder. All right. My next learning objective is I'm going to talk about risk assessment methods. So this gets into more of the clinical application of how do we do risk assessment and ways to reduce the likelihood of a suicide attempt. And then lastly, we'll talk about safety planning along the way. All right, so I'm going to do all that in 2 hours. So buckle your seatbelt and let's get going. All right. So first I want to just hit on some terminology here, just to ensure that we're all on the same page and we're using the same vocabulary. So suicide by any method continues to be the 10th leading cause of death in the United States. And if you look at different subgroups and populations, that number rises. All right. About 1 death by suicide happens every 11 minutes. So during this talk of 120 minutes, we're going to have about 11 to 12 people who die by suicide in the United States. Let me hit that number again. 11 to 12 people will die by suicide during this talk. It's sad, right? In the U.S., the most common means of suicide includes firearms, hanging, and poisoning. Men are more likely to use a firearm, and while women are more likely to use poisoning. So suicide is a fatal, self-injurious act with some evidence of intent to die. Suicide attempt is a potentially self-injurious behavior associated with at least some intent to die, all right, that you do want to no longer continue to live. All right. And then we have active suicidal ideation. So thoughts about taking action to end one's life, including identifying a method, having a plan, or having an intent to act, right? Passive suicidal ideation, this is kind of like this continuum, all right, is thoughts about suicide or wanting to be dead without any plan or intent. So let me ask you a little question. I'm an academic and I'm a teacher, so I'm going to ask you by raising your hands. So I worked in Connecticut for a while. I worked at the University of Connecticut Health Center for about 6 years, and I had a client there who would go to Foxwoods. It's a large casino there. It's tribal, and it's out kind of in the middle of nowhere, Connecticut. And so if you're in Hartford, you have to drive like 45 minutes on a divided highway that's all it is trees for a good long time. You know, and you're going up and down through some hills. It's very pretty. But the client would say to me, you know, sometimes I have these visions of just letting go of the steering wheel as I drive home from the casino. The car would maybe go off the road and end up in a ditch, and I wouldn't have to deal with this debt and hiding it from my partner. I know I won't do it, but the thought is comforting. So raise your hand if you're thinking this is active suicidal ideation. We got anybody right there? Maybe. Or is this more passive suicidal ideation, right? We're more kind of on the passive side. There is a little bit of a plan, but she says, I know I won't do it, right? All right. So, and then another client kind of said, you know, thinking about going on the dark web and using the last of my money to buy enough fentanyl to overdose. Lost my life savings, about $35,000 a couple weeks ago, recklessly gambling, and yet I still feel like I can't stop this behavior and won't ever be able to escape this reckless actions like this. On a scale of 1 to 10 now, how concerned are you about this client? Are you a 1 to 2? 3 to 4? Maybe, all right, we're getting there. 5 to 6? Getting a couple more. 6 to 7? Right? All right, now we're getting like 8, 9, right? And do we have anybody at a 10? What if I told you this person, you know, attempted suicide 3 months ago? Where are you then now, right? Are you going to go a little higher, right? Yes, much, much higher, right? And so we have those concerns. And so a person's history is also another important piece of the context of what's going on. Here's some other terms. I'm not going to get too much into it, but there's preparatory acts towards imminent suicide behaviors. This is just figuring you have the plan, and now you're going to do some behaviors that are basically launching this plan into action. And then there's non-suicidal self-injury. So that's, for example, cutting or burning oneself. And that's really the motivations for that non-suicidal self-injury is more around the desire to feel something. It's not the desire to end your life. And so it's a little bit of a different thing. It's still can be lethal at times along the way. All right. So let's talk about the prevalence of suicide. This comes from the 2020 National Survey on Drug Use and Health. This is done by the federal government. It's about 30,000 U.S. adults across the nation. And so we have basically 12.2 million Americans have had serious thoughts of suicide in the past year. That's the big gray circle. The blue circle is 3.2 million. So about a quarter made suicide plans. So they had actual plans. Then we have that green dot which says they made plans and attempted suicide. So that is, of the 12.2 million, we're now down to less than 1 million people on that side. And then we also have 1.2 million attempted suicide. So that's that whole circle. And then we have 200,000 people who made no plans and yet attempted suicide. All right? And so as a clinician, that red circle is the scariest thing, right? They didn't talk to me about it. They never disclosed it to anybody. And they didn't even really have any plans, but something happened. Some event happened, and they decided the best course of action was to attempt suicide, to take their own life. That is very scary. And we'll get into some of that. And then as you can see, about 3 to 4% of suicide attempts result in deaths. So that's about 46,000 Americans die by suicide every year. The good news is that most people with suicidal ideation do not attempt suicide, and few die by suicide. All right. And so one of the things I like to keep in mind as I am talking to clients and I'm doing this work is actually most people who express suicidal ideation do not want to end their existence, right? But rather they want to end their psychological suffering. They are in pain. They do not know how to cope with life's problems and the circumstances they find themselves in. Most people tell others that they are thinking about suicide, and it's a way of coping with their pain, right? And so we do know that. So that's a good thing, right? They're using their resources, and they're talking about that. And most suicidal people who have suicidal ideation have psychological and social interpersonal problems and limited methods to cope with that. But as clinicians, what are we good at? Are we good at helping people figure out new ways to cope with life's problems? Are we good at helping people manage psychological issues and develop new ways of responding to that? Are we good at helping people build social support and resolving issues that they have going on in lives? Yes, we are. So we can do something about suicidal ideation and thoughts of suicide. All right? And so we'll come back to this as we go through the presentation. All right, so next up is what I have is this is a brief video clip. It's about 2 to 3 minutes, and it's a story of a young man who took his own life. And I feel like this helps us kind of bring it to real life and bring it to the human cost of what happens here. And so we just have to, I want to take a moment and just acknowledge this is pretty tense. I'm going to ask you some questions as we go forward. Let me see if I push the button and it works.
Big deflection off the back of Zuma.
In England, the country's major sports leagues began pushing gambling on their fans years ago. Betting parlors began appearing inside stadiums, and Premier League teams began partnering with casino companies, generating huge income streams for the lords of British sport.
Sport, particularly football, has become increasingly reliant on revenue from gambling companies in recent years.
What do you think of the fact that nearly half of the Premier League teams have sponsorships with gambling companies?
I think it's disgusting.
They're trying to make it look normal, aren't they, as part of the game? And we know a lot of people now who watch football don't enjoy it unless they gamble.
Judith Bruni and Fran Green know firsthand. They watched as a loved one was destroyed by an addiction to sports gambling. Chris Bruni was Judith's son and Fran's boyfriend, and a promising young electrical engineer. Like Chad, he started gambling on sports and couldn't stop. And like Chad, he was given a VIP manager who facilitated his gambling habit.
Chris once came up to me, I can remember, it was from this VIP person, and he went, look at this. He says, they tried to be my best friend.
He'd get bombarded with free bets, free spins, free this, free that.
Judith and Fran say that soon after a VIP manager gifted Chris an Apple Watch, he went on a 5-day gambling binge. Chris lost tens of thousands of pounds, and then asked his VIP manager to allow him to make even bigger bets.
He did contact the VIP manager, which then they almost encouraged him to carry on.
Chris actually texted his account manager at the gambling company and said, the maximum bet on sports seems to be just under 4,000 pounds.
Yeah.
Can you extend this on my account? And the reply was, well, it won't be automatic, but have a go. They want you to bet.
Without stepping in and asking, does he need some help?
The next day, Chris lost 18,000 pounds on soccer bets. The day after, he lost 3 more big money bets.
What happened the next day?
My husband came in to me and said, you need to get up. Chris is gone. He's left a note.
What did the note say?
He just said that he loved us all, and that he needed to just disappear.
Did he mention the gambling?
Yeah, he said he couldn't fight it anymore. It had consumed him.
At the age of 25, Chris Bruni took his own life. It was just the latest in a string of suicides of young British men who'd become addicted to sports gambling.
What are some of the things that you notice in watching that story? Speak up. Yeah, he's watching the football game and he's betting on it, right? The VIP manager gave him an Apple Watch. Well, first off, nothing is free in life, right? Number two, do you think they used it to, better access to text messages and other things that they were sending him? Right? They're smart. What about the mom? Right? It is. I want to go back to, I can't get it to do it. There's a picture of her early on with Chris, right? She looks so different. Thank you, Susan. So different, right? How many years do you think she aged in that period, right? It looks like she has aged dramatically, right? So the survivors of suicide, so the family members, we're not only talking about the individual clients here, we're talking about their social network. We know that an individual with a gambling problem affects about 6 other people, at least, in their social network due to their gambling problems, right? They're connected to 6 other people. And it's a heavy, heavy heart that mother had, right? And the girlfriend, who's also there, still wanting to tell his story, and you can still see that she is shaken to her core by what has happened, right? There's more we could talk about, but I just wanted to highlight this story so that we can all just understand the human cost of suicide, not just to the individual, but to the others around them as well. This example also focused on sports betting, and I just want to say to date, there's really not one form of gambling has been shown to be more related to suicide than another one, but I think that's actually an empirical question that we have to ask in the literature and find out. There was a published paper in 2023 that found the density of casinos and other gambling venues has a small positive correlation or association with suicide mortality in the United States. It was a small but positive relationship. So we just do know that availability of gambling is somewhat associated with suicide along the way. All right. So let me give you some stats now to talk about this. So in an inpatient treatment for gambling disorder, about 80% of patients in those settings endorse suicidal ideation in their lifetime. About 40% report an attempt in their lifetime. Next up, in an outpatient treatment setting for gambling disorder, about 40% report recent suicidal ideation, and 62% report lifetime ideation. So there's a slightly lower rate of lifetime ideation, but this is common. Most of the people walking through your door in an outpatient setting will have at least had some ideation of suicidal ideation. That's not the rates that we find in the general population, right? It's somewhere between 10 and 20%, so much higher. Lastly is gambling helplines. 11 to 25% of callers endorse recent suicidal ideation. This is like past week, and 6% reported an attempt in the last year. I think the study that provides the most convincing evidence about the relationship between gambling and suicide is this is a national registry study that came out of, I think it was Sweden. Yeah, it was Sweden, where, Sweden, they have this national healthcare and they have these registries of these databases. And so they looked at the individuals from who were diagnosed with gambling disorder. So first off, you have to rise to the threshold of being identified by a provider of having a gambling disorder. We know many people do not actually ever have that happen to them, even though they have a gambling disorder. So these are individuals diagnosed with a gambling disorder, and they said, okay, we're just going to see what happens over the next 2 years with these individuals. And so they had almost a little around 2,100 individuals, and they found that about 3%, or about 70 people died over that time period. So 3% just died over this 2 years. And then they looked at the leading cause of death among those 70 people, and they found that 30% died by suicide. It was the leading cause of death for the people in this individuals with gambling disorder by magnitudes, 15 times more likely to die by suicide than any other cause of death. And 20% attempted suicide in that 2-year period. Right? It's common. All right? It is, in fact, I'm going to say normal for our clients who struggle with gambling disorder to consider ending their lives. All right? So as a clinician, you just want to say, I understand. You're not the first person to come into my office who's had these thoughts, right? To normalize it for that person, to say you're not alone, or, you know, yes, many other people have unfortunately found themselves in this situation, and they have found a path to hope. They've found a path to the future, and we can do that today together, right? So that's some of the message that you're going to have to start to say to people as you're working with them. This is unfortunately normal for your circumstances. Sadly so, but it is normal. All right, so let's talk about the risk factors for suicide. What I have up here, this is a publication from the New England Journal of Medicine. It's a very reputable journal, and basically it's a big model for how basically the risk factors for suicide on the left, it goes from left to right in the sense of the more distal things like childhood and genetics, and it moves forward to more kind of mediating sort of things or developmental things that happen along the way. And then finally, we have the proximal or precipitating events that lead to suicide. What I'd like to highlight over on the right side is there's hopelessness, there is some psychopathology, which means other psychiatric disorders, life events, right? There's some event that has happened that has really pushed things also. I want to also note over there's acute substance misuse or intoxication that frequently sometimes, because we all make great decisions when we're intoxicated, right? So what I'm not going to walk through, and there's also environmental factors around access to means, access to mental health care, media reports. We know when there's a very public suicide by a public figure, the calls to suicide crisis hotlines spike, right? We just know these things. I'm not going to walk you through all the different things. I want to say two things about this. Number one is that this is a very flat model. Different risk factors come into play at different times in your life, depending on, sort of developmental age. So people who are older adults, health problems become a big sort of an impairment where you're losing physical function actually becomes a big risk factor for suicide, versus for young adults and young people, that's not really a common risk factor or one that we pay attention to. What I am going to do is now to put some check boxes up where we know this risk factor is also found in individuals with gambling disorder. We're going to see some check boxes. Let me just tell you that right now, right? So, common in individuals with gambling disorder. Boom. That's genetics at the bottom. Next up, we got early adversity. We know individuals with gambling disorder are more likely to experience the ACEs than the general population, so the early adverse childhood events, right? Keep going. Cognitive deficits, development of, I can't read it now, that's grayed over, but you get the idea. We're keeping going, right? We're gonna keep going, right? Acute substance intoxication, hopelessness, psychopathology, life events. A family member has found out the extent of their gambling and how much financial damage they have done, and the huge, it's not only money, but the huge breach of trust that has happened, right? And the shame and ashamed feelings they have about what has happened, right? So that's these life events, right? Poor access to mental health care. Let me just go back. So you can see there's a lot of check boxes. There's just a huge overlap in the risk factors for suicide and basically know the demographic and clinical characteristics of individuals with gambling disorder, all right? It's a Venn diagram that has significant overlap. And so that's why it is somewhat normal for our clients to come in and to express suicidal ideation. All right, so let's, that covers just that first learning objective. Let's now talk about identifying risk assessment methods to help reduce the likelihood of a future suicide attempt. And so we'll walk through some different measures. Some of these you may use in your clinical practice, and then I'm going to have another piece in here. I like to think about these talks in terms of clinical nuggets. What are the 2 or 3 things that you're going to take away and take home? And so first, that was the first clinical nugget, right, that we just did, is that the overlap between gambling disorder and suicide in terms of risk factors is huge. That Venn diagram is almost a complete circle overlap, right? The next nugget is going to be around screening and assessment for suicidal ideation. All right, and then we'll talk about that safety planning at the end. So first up is talking about you as a clinician and sort of your approach and your attitudes in terms of working with clients who are going to express suicidal ideation. All right. So first one is just managing one's reaction to suicide. I remember as a very beginning trainee and earning my doctorate in clinical psychology and my first client who expressed suicidal ideation, I was freaked out. Legit, just freaked out. Like, oh my gosh, I came running to my supervisor. And they're like, take a deep breath, calm down. This is normal, right? They're telling me this is normal, right? And so we have to have some self-awareness, right? We also may have some personal beliefs about what we believe about suicide, whether it's from our religious or cultural backgrounds, all right? you know, and so we sometimes have to put that down. We also want to, you know, manage our reactions. Maybe this is the first or second time we're dealing with it. Or maybe we recently had a really bad experience where a client told us they were thinking about suicide and they had a really significant attempt on our watch, right? And so then that kind of rocks you to your core as well. So even veteran clinicians or seasoned, let's call them seasoned clinicians can still have some of these personal reactions to what's going on in the room with our clients, right? So we just have to have awareness around that and talking to and using peer consultation, right, to help, or if we have supervisors, to help kind of build some self-efficacy to do this work, right? And then we want to really reconcile the differences between the clinician's goal to prevent suicide and the client's goal to eliminate psychological pain and suffering via suicidal behavior. They are suffering. They are in extreme pain, and they don't know how to manage that, right? And so the only way they know how to manage this is to express that I'm going to end my life, right? We know that, and so that's, we have to kind of reconceptualize this. They're not really truly saying, I'm going to take my life, although a couple people are really believing that, but most are saying, I'm hurting. I'm really hurting here. I don't know what to do, right? And our answer is, well, don't do this, and let's talk about some other things we can do, all right? But that's what's going on. You got to keep that perspective in your head as you're working with people in this context, right? And then next up is maintaining a collaborative and non-stigmatizing interaction, right? So when I said like normalizing this behavior, that's not stigmatizing, right? That's almost normalizing it. And you just also want to say is we're going to work together on this. You're not by yourself, right? Because many people who are feeling suicidal are feeling unlovable, right? We're going to get to that in a minute. They're feeling very unlovable, that no one's going to care about them, no one's going to miss them, and you need to say, I'm here, I'm going to walk right next to you. We're going to do this together. We're going to collaborate to figure out how, A, to keep you safe, and then plan for the future, right? So it's a collaborative working relationship. This is not you coming down and saying, I'm going to commit you, right? That's not collaborative, right? That's like the last resort. We sometimes have to do that, right? But we want to try to really, and sometimes asking our clients, don't you think it might be better if you go inpatient right now just to settle some things down, to get them to agree with our professional opinion versus us coming down saying, you need to go inpatient right now because I'm really concerned about you and I'm going to commit you, right? That's me being authoritative. And we want to try to avoid that, but sometimes we can't, you know, but generally speaking, we want to really try to be collaborative and non-stigmatizing in our interaction. And this really gets into our basic ethics of respect for autonomy, right? For their own decision making, right? And then there's also this sort of conflicting piece of beneficence, right? Where what is best for the client. Sometimes we do have to commit clients on a 72-hour hold, right? And so we have to kind of balance some of those, but we really, I want to first start with that idea about respect for autonomy when I'm working with clients, of allowing them to make some really good decisions along the way, with my guidance and my help, right? All right, so, and the research really demonstrates that when patients sense that they are being judged or stigmatized as being deviant, they are likely to become less open with providers about their suicidal ideations and impulses. All right, so therefore, suicide ideation is framed as naturally developing symptom of distress, and disclosure of suicide ideation is regarded as a valuable communication and an invitation for collaborative problem solving. That's what it is, and that's what you want to frame to your folks when you're working with them, is that this is a valuable communication. You've told me something really important, and you probably haven't really told many other people, if anybody else at all, and together we're going to work together and make a better future. All right? And then also make a realistic assessment of one's ability and time to assess and care for a suicidal client, right? 4:30 on a Friday afternoon and you got to be home by 5 and you have some other obligations. You know, what do you do in that situation, right? So you have to make a realistic, or you have to, you know, something else is going on and, you know, you're not the one who can spend the time with the patient, but you have to find somebody who you can hand the care off to. Or sometimes you're just going to be like, well, my personal life's going to blow up for the next day or so, but I just have to take care and deal with the situation. We all have made some professional judgments in our own thing. What I would always say is that, you know, unless you're in solo private practice, there are other people around you. You're not on an island, right? And please don't ever think that it's just you who has to deal with this, is that you can really work with some other colleagues. And it's okay to say, hey, I need to step out for the room and just consult with a colleague and figure out what might be the best next step for us to take together. That's okay. They're not going to sit there and like, oh man, I am so bad, they don't even know what to do with me, right? No, that's just saying like, I want to get this situation right. I want to get this right, and so I'm going to invite them to come into the room with me, and we're going to talk all together, right? That's the way to kind of think about it. All right. So how do we assess for suicide risk? And so, suicide risk is a quick sort of process of establishing a clinical judgment of risk of suicide in the near future, all right? So, and we want to do this in a systematic way as best as we can. And so it's really to identify modifiable and treatable risk factors that inform the patient's overall treatment and management requirements. So we want to be screening our patients regularly for suicide. We want to do this and for suicidal ideation because we know 40% of them have had recent suicidal ideation, right? We know that they're thinking about this. And so by making it routine, we are normalizing this, right? There'll be a few people like, why are you asking me these questions? And then you say, well, this is actually a really common event that happens with people with gambling disorder. So we want to do this systematically, all right? It's part of your standard intake procedures, right? And from time to time, you want to have a check-in to see what's going on, right? Bottom line, we're not good at predicting suicide risk. In fact, we're pretty terrible at this. Even with machine learning and all the fancy AI stuff, it's not even 50-50 yet in terms of really predicting who's going to attempt suicide in the near future. Human beings are messy creatures is the bottom line there, right? We're not really always predictable, all right? But we still, that doesn't mean we don't try, and it doesn't mean that we don't do this, because it is better than nothing, and it's better than zero, right? So the way we do this is there is a brief screen, usually used, takes a patient, it's a self-report, usually takes about 20, 30 seconds, 5 or 6 questions at most, and then we do a brief safety assessment. I'll talk about that and how we do that, and then we'll do the further evaluation. So it's a quick thing where people can get on the off-ramp if they are, if they're deemed as being safe and okay at any point. So one of them is like the Ask Q. Some people may have used this. Does anybody also use the Columbia? Raise your hand if you guys are using the Columbia. There's some people in the room. That's a commonly used one. Does anybody use the PHQ-9? Anybody use that? Some other people are using that. It's a measure for depression, and it has the last item number 9 is about self-harm. I'll show you that. So the Columbia is a very commonly used one, so I'm going to spend some time on that rather than the Ask You. It's a simple 6-item tool about suicidal thoughts and behaviors. It's a yes-no response format, and then there's a color-coded risk stratification. You don't give the client the red, yellow one. You give them a basic one, but you can then have that, and it gives you categorization, and then leads to next steps. This is how long would it take someone to answer 6 questions, right? 20 seconds, right? That's all this takes. There's the link to it. If you just type in, Columbia Suicide Severity Rating Scale Screener, or just the Columbia Suicide in Google, boom, it'll pop up and you can see it. It looks like this. Have you wished you were dead or wish you could go to sleep and not wake up in the past month? Yes or no. You can change the time frame, but generally past month is pretty good, right? Have you actually had any thoughts about killing yourself? Yes, no. All right. If yes to question 2, answer questions 3, 4, and 5, and 6. If no, go straight to number 6. All right. You don't give a version that has these yellows and oranges and reds, right? You don't want to stigmatize your client. So you want this to be a single white piece of paper. Have you thought about how you might do this? Yes or no. Have you had any intention of acting on these thoughts of killing yourself, as opposed to you have thoughts but you definitely would not act on them? Yes or no. All of a sudden, that becomes very high risk if they're yes. Question 5, have you started to work out or worked out the details of how to kill yourself? Did you intend to carry out this plan? Yes. High risk, right? And then always ask question 6, have you done anything, started to do anything, or prepared to do anything to end your life? Yes or no, and they give you some examples, right? And they ask lifetime, you can ask past 3 months here, all right? Quick, basic question, right? And then basically the score is coded at either low, moderate, or high risk, depending on where the yes answers occur. The most worrisome answer is the same in all settings, and are they recent to questions 4 and 5, basically recent suicidal ideation that's pretty severe in terms of with intent to act, right? So you have a client who fills this out maybe in the waiting room, or they come into your office and say, before we get started, I'd like you to just do this brief suicide screener. We do this with all of our patients. Again, normalizing this and saying, I do this with everybody. You're not special, right? You just want to make that the point. So here's the dirty secret about the Columbia. I'm an academic, but this is only stats slide I'm going to show you that's like hardcore stats. So this is a recent study that kind of put together a couple different studies and reviewed them. And this is about the use of the Columbia in an emergency department. Here in Denver, Colorado is on the right, and the one on the left is in Stockholm, Sweden, and that's psychiatric patients in the ED in Stockholm. And what we have here is sensitivity and specificity. Sensitivity is the test identified a truly positive case of someone who is actually going to attempt suicide in the near future within the time period assessed. So 53% of the people who they said were high risk went on to attempt suicide in the next 30 days and the next 365 days. All right, that's the sensitivity. Said yes, and they actually followed through with on that one. Specificity is the test identified the truly negative case, where someone was identified as low risk and they did not attempt suicide within the time period assessed. We can see in Sweden that was 75% were identified as low risk and did not attempt suicide, and the same there. So we have some people on both sides of the equation who were not accurately classifying, right, over there. And then this is a general ED, where they're just, every patient who comes into the ED, they're given the Columbia, and this is what happens. And again, we're not very good at predicting who is that. Some would argue, well, if they were high risk, then we jumped in and we did some safety planning and we prevented suicide, right? But in general, these things aren't all that great, right? And it's just that we're lousy at predicting future behavior. That doesn't mean we don't take efforts, and we're still not going to have impact by doing this, but just don't hold yourself to a standard of perfection. That's the thing as a clinician. Don't hold yourself to a standard of perfection because it is not realistic and obtainable. You will make mistakes from time to time. We're all human beings, and that's okay. All right? So the bottom line is it has poor predictive validity. It's not a good tool. Doesn't mean we don't use it. It's the best tool we have today. It is the best tool that we have today, and I strongly encourage you to use it as part of what you're doing to assess suicide risk. All right? Here's the PHQ-9. This is the question they ask: is thoughts that you would be better off dead, or thoughts of hurting yourself in some way? Not at all. Several days. This is asked over the past 2 weeks. More than half the days, and nearly every day. All right. And so this is the PHQ-9 self-harm item. 3.75% of individuals endorsed a 2 or 3 on that item experienced a fatal or self-harm event over the next 18 months. All right. So maybe we jumped in and did a great job and prevented suicide or a suicide attempt, or maybe we're also just not good at identifying people. But either way, we still do this. We still jump in and do this. We don't just because it has low predictability doesn't mean we don't do this work. All right. So but don't be perfectionist. You can't be a perfectionist in this area, right? It's just not obtainable. All right. So what I'm going to encourage you, and this is the big clinical nugget I want you to take from here, is that we need to really begin to reconceptualize our understanding of suicide risk assessment and the ways we approach it. There are really 2 ways you want to start to think about your clients and the people who are presenting in your setting, is that there are some people who have chronic suicide risk. They have this enduring baseline of vulnerability to suicide and risk of suicide. All right? These are your high-risk clients who maybe have attempted suicide in the past year or so, or sometime in their recent past. Or they have this cognitive kind of triad that I'm going to get into in a minute of the UNS that is present there, that is this person things. And then we have these acute episodes of risk, which are these big acute events that push somebody over the edge, so to speak. Right? So they're time limited and driven by situational and contextual factors. All right, so if you want to think about this, is we have person A, client A, who has had a suicide attempt in the past. They're very depressed and they're feeling very hopeless about their future. They have high chronic suicide risk, and then there's an acute event and we're pouring water into a cup and we're waiting for it to overflow. This is like the diathesis stress model, if you remember back to being in school, and at some point it's going to overflow and that will lead to a suicide attempt, right? Then we have person B who has very low chronic suicide risk. They're not feeling hopeless, but all of a sudden the house of cards has come crashing down and family has found out about the extent of their gambling problem, and it's huge. And there's huge shame and embarrassment, and they don't know what they're going to do, and it is just catastrophic. And so we are just pouring a pitcher of water into that cup, and it's going to overflow. All right. So these are 2 different people. We are worried and concerned about both sets, right? As a clinician, I'm a little bit more nervous about person A, but I know person B is out there, and this thing happens. All right. All right. So There's these cognitions. There's three of them. They're called the uns. And these are core beliefs that people hold about oneself, situation, and the future. And this is how we define chronic risk, is if they're endorsing these chronic beliefs, that they are unlovable, right? No one loves me. I am a flawed and awful human being, right? If they were truly to tell you who they were and to open up and be really vulnerable with you, they would tell you that they're a terrible person, right? And that nobody would love me, right? And that their problems are unbearable, right? This is painful. It hurts. I am suffering. And that their problems are unsolvable. As a clinical psychologist, I was trained, I would say beaten into me almost, but I've been trained to think that all behavior is functional, right? People make the best choice from their perceived available choices. And suicide is a good choice when you're feeling all three of these things. It's functional. Because there is no point going forward if I'm unlovable, my problems are unbearable, and my problems are unsolvable. I just want this pain to end. That's what's going on here. So what percentage of your gambling clients believe they are an un? Throw it out there. What's your number? How many? I'm sorry, I'm hard of hearing. Both? Yeah, but what percentage would you say of people walking through your door endorse at least one of these things? 100% almost, right? A lot of them. How many do you think endorse, let's say, 3 of them? All 3. Let's go to the far side. Right? 50? Something like that? Half, right? I mean, this is why this is normal, right? 20% are endorsing active suicidal ideation, right? And so it's calling a helpline, right? Because they're feeling this, right? Maybe acutely, but there are some people who believe this to their core. They know this to be true about themselves and their situation, all right? And so what we have here is, this is a clinical example. I do like to go on Reddit, and they have a problem gambling subreddit. This is like a message board, basically, if you have never seen this, where people post stories. And so this is a story of somebody who says, I got into grad school, but had to defer a year because I had significant debt from gambling. I wouldn't be able to pay off while living off of student loans. Just lost $6,000 this past Thanksgiving, chasing loss after loss from sports betting, where my bet would fail right at the end of the game. Now I'm just trying to get back on track and find a way to pay off debts while not enjoying anything I do 24 hours a day because of the depression, destroying the reward pathways in my brain. I think about killing myself every day, but still have some fear of death and don't want to hurt family and friends. Do you see any examples of the uns in this story? Unlovable, unbearable, and unsolvable. His problems are at least unsolvable for a year. I have to defer going to grad school, right? Yep. Now I'm just trying to get back on track. Maybe it's a little bit solvable, right? All right. Here's another example of somebody. They said, I'm very tired. I'm in bed, exhausted. I feel trapped. I feel lost. I know life will go on, but I know I need help. And I don't know where to go or what to do. Inside, I feel very sad. Unlovable, unbearable, unsolvable. And the person goes on, I feel excluded. I'm a young person with a lot of life to live, but I'm killing myself living this like this. I'm refusing to try and get better. I'm choosing gambling over getting better. This is my fault, my responsibility, and it's incredibly sad that I've chosen this as a means of living when I could just not gamble and be happy. Right? So they're responsible for this terrible situation. They're saying, I'm unlovable. Right? But I'm stuck in this big time right now. Where my mental state is right now, I would probably quite like to die. Not because I don't want to live, but because I'm faced with this unbearable amount of pain and sadness. And they go on and on to continue to chronicle this story. Right? These are the people who are walking through our door. And these are the uns that they're feeling all the time. They may not tell it, and they may put on like, hey, how you doing? Oh, I'm fine. Right? No. Fine doesn't cut it here. You can't say that answer. I tell that to my clients all the time too. Like, so how are you doing? And they're like, fine. I'm like, Not happening today, not my house. How are you doing? And then you sort of get a little bit more of that real answer, right? Right? Because this is not the place where you're socially acceptable and just tell me fine, right? This is where we're going to be real, all right? So we really want to reconceptualize suicide risk as this chronic piece, all right? And then we're also now going to talk about this acute piece, right? So that's when these events happen, right? So let me first tell you about the acute episode of risk. So what might be some event that might happen for a person with a gambling disorder that would be an acute event that would basically fill up that cup and start for it to overflow in terms of suicidal ideation? Please, over here.
This is a sure bet.
Sure bet, right? I'm going to hit.
I'm convinced.
And I'm going to get back all the money I lost. I'm going to get back to my break even, right? That could be it, and then they lose $10,000.
I think a breaking point would be I can't pay the mortgage, and my wife doesn't know, and they're going to take the house.
I don't know what we're going to do, right? And they've been hiding the notices around they're behind on the payments, right? And they don't see a path forward there. Please. I'm sorry, someone else? Someone important to them dies. And so there's just a huge stressor of life gets put on them and they don't see a way out. Yes?
Someone discovers their secret.
Discovers their secret. Mm-hmm. Right? And that house of cards and the robbing Peter to pay Paul and all the lies. Psh, right? It's really funny. I'm going to go on a quick aside about that. Is when I work with individuals with gambling problems, they come in and they tell me they were forced in by family because they're like, you got to go to treatment, you know. And they come in and they're like, oh, whew, that's over. You know, at least like, you know, and I'm on to the path to recovery and everything's going to be fine. I'm going to work really hard and everything's good. I don't understand why my family's still pissed off at me, right? And I'm like, do you understand what just happened to them? And like, they were in crisis mode, right? They discovered all this bad stuff, and now you've walked in the door, and you're like, oh, everything's fine now. I'm going to deal with this. I'm going to take care of my gambling problem. They're now sitting there. They're taking the deep breath, and they're surveying the damage that has been done, not only financially, but that breach in trust in that relationship and what they thought they knew about you and who you were. And they are angry. And I'm telling you, it's going to be a while before that anger dissipates. We can do some family sessions and things like that, but it's going to take a little while, and you just got to buckle your seatbelt because you're in for a ride, right? This is not something that's going to fix itself overnight, right? So we have to do that. All right, but let me just talk to you. This is a stat. This is another stat. When I saw this just floored me. Is from this comes from an inpatient sample. It's Germany, but I still think it applies to the U.S. of people who had attempted suicide, and they asked them, from the moment you thought about attempting suicide, how much time elapsed from you taking action to actually end your life? 36% said 5 minutes. Just like that. That's a third, right? 44, almost half said 10 minutes. Oh, dear God, right? And then 3/4 basically was within 3 hours. That's your people who hem and haw a little bit, right? But still, 3 hours. That's not much time. Even 3 hours, right? But almost half within 10 minutes. That is scary. As that clinician, right? That's that circle I put up of people who maybe didn't have a plan, but they attempted suicide, right? But still, the bottom line is this is really scary. This is that acute piece, right, that happens for people because the guilt and the shame is so overwhelming because the house of cards has come falling down, right? They're now exposed for who they really are, and that's really scary along those lines. And they're unlovable, unbearable, and unsolvable, right? All right, so what this is another cool study that I really like. I think this really hits on the point. So this is how many people? This is 54 adults, about 8% women, who attempted suicide within the past year at least once. So this is a sample with high severity for suicidal ideation. And this is what's called an ecological momentary assessment study. Basically, it's back in the day, it was called a beeper study. It's basically they ping you 4 times a day, and they ask you how about your feelings of suicidal ideation. And they followed people for 28 days. So that 80 is actually 4 times 28, and actually goes a little bit past that, right? So this is basically a month's worth of data of pinging people 4 times a day saying, tell me about your suicidal ideation. So this is a chronic group of people, and what you see are wide fluctuations in this data. And so this is people are averaged for themselves. So every person gets an average for themselves of 0. Everybody has a slightly different set point on this questionnaire. And then they just graph themselves over time, and you can see within themselves, there's huge fluctuations. I mean, let's follow like the purple through the thing, right? A little bit below average, something happens, come back down, something happens, go back down, maybe I talk to my therapist, something happens, and I'm up, there's my another, maybe reach out to a therapist, I had coffee with a friend, going up and down, down, up and down a little bit, right? We see this is a pattern, this is their life. This is reality for some of the people that we're working with, all right? That has to be awful. That is not a way that I'd want to live my life, right? To be in this spot and to feel that over 28 days. It's exhausting, right? And the turmoil that's within them is really just there, right? All right. So suicidal ideation changes by the day and the hour. That's the take-home message from there. All right. So thinking about individuals with gambling disorder, what are some situations or acute factors they may encounter that potentially contribute to an acute episode of risk? We hit on that. I'm not going to go back to that, but I want to make sure that we're thinking about those acute episodes of what could cause that spike, and talking to our clients about those acute episodes that maybe they haven't disclosed to their family yet, the gambling problem. They're coming in on their own quietly and in the dark, right? And they haven't told family yet. And so then when family finds out, that could be an acute episode of risk. And you got to do some game planning around that. All right. So here's an acute episode. This is again from Reddit. It said, so I managed to stay gambling free from December 7th to the beginning of March. Then I fell into temptation and actually hit my biggest win ever, turned $400 into $30,000. Was absolutely ecstatic, right? That's our gambler riding the high, right? Then I kept playing and lost it all. It's a very familiar story, right? Very familiar story for the people we work with, unfortunately. The next day I deposited $3,000 to try to get it back, and it worked, right? I was up $45,000 at one point. Then I kept playing and I lost it all down to $3,000, which I actually withdrew. So in actuality, I've only lost $400, but I feel like I've lost so much more, right? Gambling is not always about the money. I feel like I've lost so much more. I'm so disappointed in myself. It's not even just about the money. It's the it's the absolute anguish and self-hatred and the constant fixation and obsession with gambling that is back, and I hate it. Can you feel this person? They can't even stand to be in their own skin, right? Oh my gosh. At a point after I quit on December 7th, there were actually days where I didn't even think about gambling, right? I started fantasizing about what to do with the $45,000. Imagine what I could have done with my family. I could have paid off all my debt, but instead I'm on square one, that regret, right? I've battled most addictions in my life, alcoholism, drug addiction, etc. But gambling addiction is the only one that I've actually seriously considered suicide because I'm so bleeping done, right? I mean, this is like an acute episode that kind of like is over several weeks, but you can see how this relapse, I mean, I haven't used that word yet, but relapse is an acute episode of risk as well. Because they're like, I'm back at square zero. Not even square one, square zero, right? So relapse is another one that we have to think about. Now imagine if this individual was highly impulsive and was drinking and had access to a firearm. Right? So again, acute episodes of risk, and there's some shades of gray in there too. All right. So we can definitely keep using our PHQ-9 or our Columbia, all right? But what I want to introduce is I want to encourage you in your clinical practice to introduce the brief suicide cognition scale. This will assess a client's chronic risk for suicide. This is a 6-item questionnaire. So again, it's on a Likert scale 1 to 5, so strongly disagree to agree. All right, it's free to use. I get no money off. Nobody gets any money off of this. They just want them to, the people who created this scale just want people to use it. All right? Scores 13 and higher indicate high risk for chronic suicidal ideation. All right? And here's what it looks like. Here's the PHQ-9, and then you would like this, the 0 through 3. All right? But here is the brief suicide cognition scale. All right? I'm completely unworthy of love. 1 through 5. That's the unlovable, right? Nothing can help me solve my problems. Right? What's that? Unsolvable, right? I can't cope with my problems any longer. Unbearable. Thank you. Let's keep going, right? I can't imagine anyone being able to withstand this kind of pain. Unbearable, right? There's nothing redeeming about me. Unlovable, right? Suicide is the only way to end this pain. Unsolvable, right? Scores 13 and higher. So if you take these three, if you neither disagree or agree on all these items, you're a 3, that's a score of 18. Score of 13 or higher, right? So you really you're endorsing only 1 and 2s across all of this. Right? If you're a 2, you're on each of these, you're at a 12. All right? This is free, this is quick. But it gives you really good information about what's going on. And imagine the conversations you can have with your clients based off of this information. That's what I'm saying, is imagine the conversations that come from here, right? If you type in the brief suicide cognition scale, you can find this online pretty quickly and easy. Or you can take a picture. My presentation's available. You can just take this and use this, right? It is free. Dr. Rudd, who's now at the University of Memphis, is one of the originators of this measure, to give him credit along those lines. All right? This is the other nugget I want to take, one of the nuggets I want you to take with you, is think about this questionnaire and think about it as routine screening that you use with your clients. All right? This is just systematic that you do with everybody because we know many of your clients are experiencing these thoughts. All right? These are core beliefs that they hold about themselves. And if you work from a CBT framework, core beliefs are really important to assess, to bring out into the open, and talk about and work on some cognitive reframing and restructuring around. All right? All right. So, does the conversation between person A and person B look the same? No, it's a little bit different, right? They're both very important conversations, right? But you might want to talk about more with these acute episodes and try to forecast what that might be for person B, right? Versus person A, you're more on the core beliefs of the uns, along the lines of there. But they are somewhat different. And so that's why this is a tool with clinical utility, that brief cognition scale, suicide cognition scale. All right. So screening, by the way, is just the start of the conversation. That was 20 seconds, 30 seconds. And then you got to do something with that information, right? And that's just the conversation about suicide and the pain and suffering the client is experiencing. So next up is a brief safety assessment, all right? So I just want to highlight, this is the middle piece of the talk, is that we are really here about reconceptualizing it as both chronic and acute risk. That's the way I want you to start thinking about suicide within your clinical practice or in other settings you may be working with. And individuals with gambling disorder present with both chronic and acute risk, all right? All right, we're going to take a little stretch break. Not the whole 2 minutes, but you've been great so far. Just stand up. We've been going for an hour, and you just need to do a little movement, right? We all need that. This is a long day in this room. Please, just take 2 minutes, and we will come right back. So we are now on to the last piece about safety planning with an individual who reports current suicidal ideation or intent. All right, so we're on the last learning objective here. And so again, we're going to go back to clinician experience and attitude, that this is really important. All right, so first off, self-efficacy is another word for confidence. So a clinician's confidence to work with a client endorsing suicidal ideation has an impact upon effectively engaging with a client endorsing suicidal ideation. So if you are confident, you're calm, cool, and collected, your client will feel at ease a little bit more so. It's still a highly distressing moment, but we do know that. But the thing is when you survey mental health clinicians and you ask them, what is your greatest concern, your greatest fear? It's about the prospect of losing a client to suicide. It is our number one fear, right? That a client will take their own life, right? It is common, right? that we have this. And unfortunately for some people, this is a part of your practice. I was attending a training, it was put on by the American Psychological Association, their trust, and they said about 25% of licensed psychologists will lose a client to suicide in their professional career. So this happens even despite our best efforts. I don't know what the broader stats are beyond licensed psychologists, but I imagine it's much the same. All right? So this happens. But we need to have some self-efficacy, and if you don't feel comfortable and confident, go get support, go get some training. You know, peer consultation is a wonderful thing as well, to build that confidence and that self-efficacy. All right? So, again, about this attitude is, as clinicians, we must really find a way to be empathic of the client's suicidal wish. To say, I hear you. You know, but what I'm going to do is try to change your language. Say, I hear you saying this is unsolvable. I hear you saying this is unbearable. I hear you saying you're unlovable. That's having some empathy for their situation and their wish, all right? But it allows for that connection with them, and it allows for the collaboration that you're going to have to do without necessarily endorsing suicide as a means of coping with that pain and suffering, all right? We need to find a way to say, I hear you. This is unbearable and unsolvable. That's what you're feeling right now, and there's a lot of pain and a lot of suffering that you're having right now, right? All right? But while it can be really stressful to talk about suicide, like our own heart rate will be going up. It'll be ticking up, boom, 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 right? Clinicians must dive in and trust that we can speak candidly with our clients with competence, confidence, and compassion, right? It can make all the difference, right? So we have to be wary of the fact that suicide risk assessment also then, it becomes automatic. If you're handing this to every new client as they walk in through the door, you're like, okay, let me see your suicide questionnaires. Okay, we're good. Or, oh, you see your doors, yes. Right? Because it's our everyday, you know? And depending on your role, maybe you're the intake clinician and you're the one who sees this every day, 2 or 3 times a day, right? That's so, you know, we just can't become habituated to it. That each person has a story and has feelings, and we have to, not become sort of numb to the fact that people are saying, yeah, I have thoughts about harming myself. And sometimes that might even be protective, right? There is such things as vicarious trauma or secondary trauma, things like that. These do happen, and by hearing these stories over and over, that can happen. So we have to figure out ways, A, for some self-care, but B, not to lose sight of the human beings in front of us, all right? So we need to really take a person-centered approach to our risk assessment intervention. We need to engage in really active listening, generating some trust, and conveying respect for the person, and being genuine in the moment, having empathy, and responding with to the concerns the person is sharing with you, right? The way the questions are asked can help convey a sense of empathy, but also normalization. So we have to do both of those. We can't be, some clinicians, at least initially, you're like, I'm afraid if I ask about suicide, that's going to make them suicidal. No, that's been so debunked, right? And that's not true. We have to do this, and we have to normalize it, all right? Because if we ask, then that normalizes and says this is something, and we know we have effective ways to engage in safety planning to reduce the risk of suicide along the way. All right? So if I can demonstrate that I can talk about this, I'm ready to talk about it, I'm going to listen, and I'm really going to hear you, that conversation is going to be so much more open and collaborative along the way. All right, so here are the steps we have to do. So you have a client who is identified as moderate to high risk based off your risk assessment, your screeners that you've done. All right? And so here are the actions, and so this is a evidence-based intervention, and it's called safety planning, and it works. One study found that this intervention was associated with a 45% reduction in suicidal behaviors over time, which was significantly better than the standard of care comparison intervention that they ran when they did this clinical trial. The intervention approximately halved the odds of suicidal behavior over 6 months. All right, so this works. One client said, I'm going to get into what this is, the safety planning, said, it gave me the opportunity to more clearly define the signs when my mood is beginning to deteriorate and when to start taking steps to prevent further worsening. All right, so Stanley and Brown are the folks who created this intervention, and these are the steps. Is basically you're going to obtain a crisis narrative, get their story, and understand the antecedents behind and or what brings out that desire, that thought for suicide, and really get a good understanding of what's going on. And from that crisis narrative, then you're going to do some psychoeducation about suicide, normalize it, say it's common, and then we're going to do a very brief intervention. All this takes about 45 minutes, all right? It takes about 45 minutes if you're going to do this well. The crisis narrative takes about 20 minutes to really get somebody's story, all right, around the events that led and precipitated to suicidal ideation, and then it's another 20 minutes for these next two pieces, about 10 minutes, five minutes on the education, and the brief interventions maybe 10 to 15 minutes, okay? And so this is what it's all about. And then you're going to complete the brief intervention. You're going to do some check in on the feasibility of their plan. And then the client's going to put this into action. And then you're going to have hopefully some ongoing follow-up, right? Because we know that this is not something that's just going to go away tomorrow, right? There's not a magic pill that you can swallow that's going to make the world a better place magically. There's no miracle cure like that for suicidal ideation, right? So what we're going to do here is the crisis narrative and what you're supposed to do here. All right, and you're going to be looking for when you're, tell me about what happened. Tell me the story of how you found yourself in this spot, right? So ask the client to describe the timeline of events for a suicidal episode that led up to the crisis. Let's talk about your suicide attempt. What's been going on lately? That's just a great open-ended question, right? And then you're going to take it from there. Can you tell me the story of what happened? And as they're telling their story, you're going to be looking for those uns, right? Unlovable, unbearable, unsolvable, right? Another good question is I see your struggle. I hear your suffering. And I understand why you have these suicidal thoughts. What do we make of you still being alive and not already dead by suicide? Basically, how come you haven't done it yet? I don't want to kind of frame it that plainly and that bluntly, but, you're still here. That gets that message of, there's a grain of hope in there somewhere, and you want to also hear that too. But what you're really trying to get is a good understanding of the story, and what are the antecedents? What are the things, that bring out those thoughts of harming themselves, of ending their life? What is happening? And the thing is, it's somewhat going to be a consistent pattern for somebody, right? So you want to assess the events, thoughts, emotions, physical sensations. Don't forget to attend to that channel. Right? There's these thought channels, there's the emotional channel, and the physical sensations and behaviors, right? What happened next? What were you saying to yourself at this point? And you're going to be looking for the uns, right? Did you notice any sensations in your body at that point? Yeah, I got very tingly, or maybe there was some derealization where they're sort of outside of their body and they're looking in. You want to get those senses, or some dissociation happening. And maybe signs of dissociation is one of the things that you want to attend to when you're doing this, when you're looking about what are the antecedents for the person. So you really want to assess all these different components of what is happening and what happened before. And sometimes clients aren't the best reporters, and you just got to slow stuff down, right? And you got to really just sit there and ask moment by moment. All right, take me back to before you were feeling this way. When was the last time you remember feeling sort of okay or not having these thoughts? And then you walk them slowly through, what happened next? What happened next? What were you thinking when that happened, right? How are you feeling emotionally? What was going on there? So sometimes you have to go kind of really slow through all this because they're not really aware of all the things. Everything's kind of happened and they don't know what happened, right? So you got to slow it down a little bit. But you're getting their story. And by getting this, you're also saying, I'm listening, I care about you, and I want to help you. That's the implicit message that you may want to make somewhat explicit, but that's the implicit message you're getting by asking all these questions, right? And really, then we're going to move into some psychoeducation. And this is, again, about helping individuals view these psychological states, the suicidal ideation, as changeable, as something that we can modify rather than it's just this fixed thing that is always going to be a part of my life, right? And so we want to really cover that suicide ideation and attempts are common in individuals with gambling problems. 40 to 50% experience suicidal ideation, right? And 10 to 20% have attempts, right? This is common. This is normal. Unfortunately, you're not the first person to do that, right? All right? It offers a way to provide validation and support for the client's story and situation. They've just told you their story. You have a good understanding, and you want to say, unfortunately, you're not the only person to come in and say this. We know that individuals with gambling disorder struggle with suicidal ideation. About half the people who walk through my door say that, and about 10 to 20% actually have attempted suicide. So you're not revolutionary. You're not necessarily unique in this way. Not discounting your story, though, and it's really important, but you're not alone. You're not the first person to say this. And unfortunately, gambling brings this about. So this is just another expression of your gambling disorder. This is another symptom, cause, or consequence of your gambling disorder. All right? It's not you that you're defective. Right? All right? And then we want to talk about the biopsychosocial model of suicidal behaviors. We want to talk about how when they're feeling very emotionally dysregulated, their problems feel very much unbearable, right? Lack of social connection, right? That they've lost people, whether through death or through their gambling, because gambling narrows your world down, right? There are few people that you can really be open and honest with and have connection with, because you're robbing Peter to pay Paul, and you have to hide all this, and you don't want people to know about your whereabouts and all those sorts of things. So you want to highlight some of that you become socially isolated, and that's really that's a risk factor for suicide, and that's common in people with gambling disorder. The perceived burdenness, they don't see a way out. I just lost $10,000, and I don't know how I'm going to recover. I don't know how I'm going to pay the mortgage this month, right? And that unsolvable. I don't know what I'm going to do. And so it really provides that validation of what's going on. All right? And then, and then we also say, like, you're having this crisis, right? And that's going to intensify all these feelings all that much more, right? And that's what's bringing out these thoughts of harming yourself and the suicidal behaviors, right? That's what's happening. This is a consequence or an outcome of your gambling disorder, all right? We somewhat, in some ways, we sort of, I don't want to say expect it, but it's not unexpected, right, in terms of what's happening with individuals with gambling disorder. And so we're all just kind of normalizing, saying this happens. And I'm really sad that you're in this spot, that gambling has gotten this far down, out of control for you, right? That this has happened, right? And so we have to do something. But you're not the first, you're not the last, sadly. But we're here together because there is a way forward, and there's a way to have hope. All right? And the thing is, these thoughts of suicide, and actually maybe some of the behaviors, are ways to respond and regulate these intense emotions, and also a way to communicate your distress to other people, and a way to actually potentially solve the problem, right? All behavior is functional, that this is a way that you're going to solve your problems. It's not the choice that we hope you make, but it is one option among many. And you kind of have to say that. This is one option among many. I hope it's the option you don't choose. I don't want that for you, but it is on the table, right? And so with suicidal behaviors, they are functional. They are telling you something very important is going on. Let's listen to that message, what your body is telling you, what your brain is telling you. This can't go on anymore. This has to end, right? I say, yes, it does have to end, but I'm going to help you end it in a way that helps you have a path to a better future, all right? So that's the education piece that you want to do, and that this experience is temporary, and we have our little graph of people bouncing up. This is the chronic folks, right? But this experience is temporary. This too shall pass, if we want to lean on our 12-step traditions, right? This too shall pass. All right. Here's a nice handout. This is another way. This is done in a group therapy sort of context, is understanding your suicidal thoughts and behaviors. And it talks more about the lifespan sort of approach to early life and how that may set you up for a gambling disorder. But you do this in a group context, and you can really have people tell their stories and share their stories, like, impulsivity. That's common with people with gambling disorder. It's also common with individuals who are experiencing suicidal ideation. Anybody have any stories about how they did some impulsive things? And you get one person who's brave and they share their story, and all of a sudden 3 other people are like, oh, that's me. Or I see a version of myself in your story. And you get that social connection that we desperately want for our clients, right? And then you get the power of the group, the power of the room happening along those lines. And so you can, this handout can take an hour if you're good at getting people to talk to each other and share their stories about what's going on along those lines, all right? And if you go into Google Scholar and you type in this author and suicide psychoeducation, you'll find this handout, and you can take it and use it, and it's free to use along the way. All right? All right. So that is also psychoeducation as well. That's more of a group setting way, but you can just do this. So, if you're running an outpatient treatment clinic, hopefully as part of your just standard curriculum, you have suicide psychoeducation in there built in because we know it's common with our gambling disorder clients. All right? Hopefully it's maybe more on the early side than the later side, but it's there. All right? All right, and now we're moving into the brief interventions for individuals with moderate to high risk for suicide, but who do not require immediate rescue, meaning I'm not concerned and having conversations about maybe you need to have inpatient stabilization for 72 hours. I'm not at that place with them. I'm more like, okay, I feel like that you're in a spot where we can, you're free to go at the end of today's session, and I'm not concerned that you're going to do something imminent right now. Right? And so, there's a different course if you have to take the route of they need inpatient stabilization. All right, first off, this is the only thing I'm going to tell you not to do. This is the only time I say, no. And the thing is when I was first being trained back in the late 90s, this was the standard of what we did, right? And now we know that this doesn't work. We don't do no harm, no suicide contracts, where I say, I, Jeremiah Weinstock, will not harm myself between now and my next appointment on today's what, the 19th, so next week on the 28th. Sign my name, boom, done, right? We don't do that anymore, all right? That does, because what that is saying is I, as a therapist, believe you are at risk for suicide. And I'm going to take your word for it. That is malpractice. You're setting yourself up for a lawsuit, all right? Not that many people do sue when clients do commit suicide, but you're setting yourself up because you're saying, I know you're at imminent risk, and I'm going to just have you say, Scout's honor, I'm not going to do it, right? That doesn't work. So this is the only time I ever say, and I'm not somebody who tries to be prescriptive, but this is the only time I'm going to say, no, we don't do this. Stop, all right? What we do is brief intervention around safety planning. There are a couple different versions of this. It's like Baskin-Robbins. They have 31 flavors. They're all good. It's all ice cream, right? But one's called Patient Safety Plan. That's the Stanley and Brown one. Or the Crisis Response Plan. That's the Rudd one. Doesn't matter which one it does, all right? All right, so we want to really take this approach of these. I'm just looking at my notes for a second. So basically, the patient safety plan is a stepwise increase in level of intervention, and it starts with, okay, the client's starting to become aware of some of the risks or the situations that put them in acute distress and create thoughts of suicide, right? And it basically says, okay, well, what can you do first by yourself? And then it starts to broaden in the funnel of who you can reach out and what you can do. All right. So you can find this template at this website at the bottom. If you just type in the patient safety plan template into Google, you can find this as well. And so you're going to sit there with a client and fill out this form. I like to have 2 copies, one for the client and one for me, because they're going to take home theirs written in their own language, in their own handwriting, and I'm going to have one that I'm going to put in their file. Right? I'm going to scan it in and put it into my EHR, right? So warning signs, right? Thoughts, images, mood, situation, behavior. It doesn't have the physical sensation. That's my one critique of this one, right? But still, you can add that yourself. That a crisis might be developing. It's on the horizon, right? And from the crisis narrative that you've obtained from the client, you know this information. And so you're not going to tell the client directly that what you know. You're going to ask them questions to get them to answer that and write those things down, right? It's like the old school Socratic questioning. Because if they say it, it's so much more powerful. Yes, it's quicker and easier for you to be like, okay, I know what it is, boom, 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 write that down, right? We have to get them to say it because then it becomes more powerful and more real that they're the ones who are like, oh, I wrote that down, I know it, right? It's think it, don't ink it, right? And then step 2 is these internal strategies, things I can do to take my mind off my problems without contacting another person. Relaxation technique, physical activity, things like that. One of the things I like to do, I use it for urges, for gambling urges, but it applies here. I'll say to a client, okay, I want you to go, it used to be when I first started, I want you to go over the microwave and set the timer. Now it's like pull out your phone, set the timer on your phone, right? But I want you to set the timer for 20 minutes. And I want you to go like read a book, turn on TV, watch some mindless TV. We all have our favorites, right? And so turn on some mindless TV or, go for a walk, whatever it may be, go do something for 20 minutes. Come back after that 20 minutes and reevaluate and figure out what you want to do next, right? Do you need another 20 minutes? Or has the urge to gamble or the thoughts of suicide, have they lessened somewhat? And are you moving there? Frequently we teach like if you're experienced in DBT, dialectical behavior therapy, you may be doing some grounding techniques. or you're doing some deep breathing or some progressive muscle relaxation. The client will have some skills, or maybe these are some of the skills that you need to teach them. And you say, you know what, we can't do it today, but I'm going to teach you a relaxation technique next time you come in. I'm instilling hope, right? I'm going to teach you a skill next time that you can use for these situations, all right? And the safety plan is a method for helping the person to recognize the warning signs and to take action to reduce the risk or keep it from escalating. So be out on the look for. Sometimes clients may be ambivalent about the goals of safety planning in such a way that really prevents them from really engaging in doing this form with you, right? And so in a non-judgmental manner, you just want to say, you know, I noticed that you're feeling somewhat like ambivalent about doing this form. Can you tell me why you're having some trouble engaging in doing this task with me, right? And then you're going to pause doing this, and you're going to say, what's going on, right? And just take a moment and do that, you know? And you're going to use the patient's narrative to say, I understand that you're suffering and you're in pain, and this is the path forward. We know this works. 45% reduction in suicide behaviors over 6 months. That's what this intervention does. I know this works. This is evidence-based care, and I'm going to do this with you. And then also, I'm going to do this, right? And we're going to use these strategies to give you a sense of, I know what to do, and build some confidence that I can manage these situations and I can manage my emotions. It's no longer I am emotionally dysregulated and all over the place, and I'm feeling just all these uns, right? These are the things you can do. Next up is step 3 is, who are the people in social settings that provide distraction? This is not the person I'm to disclose that I'm saying there I'm feeling suicidal. No, this is just another version of distraction. Who can I call up and say, hey, how you doing? What's going on? You know? And I'll give that socially acceptable answer of, I'm fine, things are good, right? But then you're just having distraction, but you're also having connection with another human being. Who are the people? Sometimes this is really hard because they don't have anybody. That's when it's like, okay, we have identified something that we need to work on, is you do not have a social support network. And every human being needs a social support network. Maybe your family is dysfunctional and you're no contact with them, so that's not an appropriate person. But is there anybody, even like a colleague from work, that you could maybe reach out to? Or somebody in your past that you just maybe could call up and say, hey, what's going on? I haven't heard from you in a while, right? So, it's those sorts of things. Are there places we can go, right? There's a recent stat. Recently, I read an article about third places. I don't know if people know about this. So your first place is your home, your second place is where you work, and third place is where everybody knows your name. It's like Cheers, right? Norm and Cheers. It's the places in America we have lost our third places. We've lost our churches, synagogues, mosques, right? People are not going there regularly. We've lost places where we get community. Growing up, I was highly involved in 4-H, and that was my community, right? And so where do you get community? And we don't have these places as much, very much. It's like there's recently someone was saying, I saw something that adults are, like young adults, on average spend 3 hours in person with friends across a week, when it used to be like 20 hours. I'm like, I can't, like when I went through college, we were always hanging out with your friends and doing stuff. I can't, like it's just a different way of being today, and I don't think it's the way that human beings are at least built. We're built for social connection. We're social creatures. So we need to identify some places. This is also a great place to make your plug for GA. Right? That's a great place for people. And where people are going to know your name and they're going to understand that. So who's going to help you take your mind off your problems, at least for a little while? Who helps you feel better when you socialize with them? That's some of the questions you could ask. Who can you contact who helps you take your mind off your problems, right? We just want to identify people who you're not going to disclose that you're feeling suicidal, but you're just going to talk to, right? My friend Bob likes to watch football. So when I'm feeling down, I can go watch football, or I can call him up and just talk to him about the game. Last week's game. I just had a conversation with a friend last night about how I'm from Philadelphia and how my Eagles totally blew it, right? And that's a great conversation. I'm very sad, but I'm not disclosing my suicidal ideation, right? And thank God I didn't bet on the game, right? I'm not a sports bettor, right? But and unfortunately, this friend is a Cowboys fan. And so we had a little he's like, sorry, not sorry, sort of thing. And like, don't talk to me about your problems. I got problems too, right? Because they're a Cowboys fan, they got blown out. So anyway, we got that going on. And we had social connection though. There was bonding, right, over our woes. So we want that. That's what you want. Those sorts of things, those sorts of situations. Next up, people I can ask for help. People I can share, I can open and show my true self. I can be vulnerable and say, I am struggling today. Today's hard. It's a hard day. Who are those people in your life you can get? And again, they might got nobody, right? And you say, okay, this is a thing that we need to work on, and this is one of our goals for Treatment Together is to identify and help you build some social support. Again, GA, great place. I'm a big proponent of GA. I really encourage all my clients to give it a try. It's not for everybody, you know, and there are some other options out there like Smart Recovery and things like that. You know, Celebrate Recovery if they're that religious background, things like that. Any of those are acceptable options as long as they're getting social support and it's not in a way that is harmful to them, all right? I had a client, I'll say, who had a gambling problem, and they were in rural Missouri, and the only real option for them was Celebrate Recovery. But they were also a member of the LGBT community, and so they could not disclose that aspect of their identity. And so we had to do a lot of work around, like, what are you doing, like, about this? Like, is this really... We had to have a long conversation about, is this really helpful to you? Because you cannot be authentic in this setting, right? And so she's like, I got no other choice. I'm in rural Missouri. What am I going to do? This is the only choice I have, the only option, you know? And I was like, but you can't be real. And this is part of the problem, is you are experiencing a lot of shame. And some of the shame was about her LGBTQ background. And I'm like, all this is doing is activating you. You know, and unfortunately, there's not a happy ending with that story, unfortunately. She discontinued treatment after a while, and I don't know what happened, right? Because the shame was too much. All right, next up is professional or agencies I can contact. So that's your crisis support thing. This is a little bit older, this form, because it doesn't have the 988, right? But it's the old one. They do have an updated version, I imagine. So, and basically who you're going to call and what's going to happen. And then lastly is making the environment safe. All right, this is a challenging conversation that you're going to have with folks sometimes, right? That thing about making the environment safe. So goal is discuss how having easy access to lethal means, because we know, what is it, 33% within 3 minutes, right? We want to make barriers. We want to make it harder to obstruct you so that you can't, within 3 minutes of having the thought of suicide, actually act on it, right? So the goal here is to reduce that access to lethal means that places the individual at greater risk for suicide and does not allow enough time to use the coping strategies that we're going to work on, or the sources of support that we just previously identified, right? I want to have some opportunity. We're all talking about with our gamblers, we just want them to have that moment of pause, whether it's when they're gambling or when they're feeling suicidal, of like, stop and take a deep breath and survey the situation and figure out what my next step is, right? We want that, right? We don't want it to be smooth sailing right into gambling or smooth sailing right into picking up our firearm, right? Our loaded firearm. So for each method that is identified, determine that individual's access to lethal means and collaborate to find voluntary options that reduce access to lethal method and make the environment safe, right? That's easier said than done, right? Much easier said than done. I can get up and tell you that, right? So one of the things we suggest you do is do a pros and cons of taking that action versus not taking that action. What are the pros? You have a firearm in your bedside table and it's loaded, right? High risk sort of thing. That is not a safe environment, right? But you know, I have my Second Amendment right to my gun. And if you're talking about taking away my gun, right, that can be a part of the conversation, unfortunately, right? You know, we do live in a society where we do have those freedoms, right? So we talk about the pros and cons of giving my firearm and ammunition. And by the way, we use the word firearm, all right? We don't use the word gun because gun can be very activating or has certain connotations. We use the word firearm because that just sort of takes the temperature down on the conversation just a little bit. So we use the word firearm and ammunition to my brother temporarily for safekeeping. That's one action I can take. The other is keeping my loaded firearm on my bedside table. What are the pros and cons of giving it to your brother? What are the pros and cons of the firearm in my bedside table? All right, I'm not going to have, this was when I did this webinar, but you could think about what are those pros and cons right there. What are the pros and cons of keeping it in your table, right? And so we can think about how to fill that out. And you may have to suggest some things or say, you know, I'm wondering if this might be a pro for you, is that you would actually have to disclose to your brother that you're feeling suicidal. I'm wondering if that might be a means to build some social support. Oh, right? Because that might go in the con column. I'm going to have to disclose to my brother that I'm suicidal. He's going to think I'm crazy, right? He's going to think I'm going off the deep end. Oh, let's try to flip that into a pro. right? And then the pros and cons here. So we want to think and try to be really collaborative. And so collaboration piece is I'm wondering, I'm curious, right, as you lead into what you want to write down on that pro and con. Because you know in your head what you want to put down there. You've maybe done this a couple times, or you have some ideas, or they're not saying. So it's like, I'm wondering. You know, it's the Columbo method, right, if you're of that age. Right? I'm wondering here, I got this idea, right? Or, you know, I'm curious about. These are the things we can do. And so you can spend some time with your clients doing this. So this is what it looks like as a full sheet of paper that they have filled out. And so then at the end, this is that feasibility check, is what could keep you from using this safety plan when you start to feel suicidal, right? By the way, also, where are you going to keep this? I don't want anybody to see this. Okay, so the refrigerator is not a good spot. But for some people, the refrigerator is the best spot, right? So where are you going to keep this? Okay, I'm going to keep it in my purse, all right? If it's like my wife's purse, God help you if you're ever going to find it again, right? Or another person said, well, I'm going to take a picture of it. I don't want this to leave this office. I don't want anybody to find it, but I'm going to take a picture and I'll have it on my phone. I'm like, that's great, all right? So we like, that's thinking creatively outside the box. Things like that. So you want to do this, and you want them, and you're going to have a copy, and they're going to have a copy, right? And you're going to review and revise over time. You're going to see them next week when they come back in. You're going to say, so how'd it go this week? Let's talk about this plan. Any adjustments you want to make? Was this working for you? What was working? What wasn't working? All those sorts of questions you want to ask, right? Because that's that feasibility check that you do. Yeah, and how accessible is it is the question there, right? All right, so we're getting close to an end here. Here's the crisis response plan. This is just another one. This is an index card. That's what they use, and it's very much the same sort of thing. The only thing that's a little bit different is the reasons to live over here. They have mom, they have wife, they have kids, photography, and motorcycle rides, right? You can incorporate that in the patient safety plan as well. This is you say potato, I say potato. Has a lot of the same information. It's just more, what are you more comfortable with? What do you want to use? And both are really things that are doing that. But the reasons for living is important because it provides a sense of meaning and purpose in the client's life, right? And that's what we're going for there. And that's why sometimes that can be helpful. And that's why I wanted to show you this version as well. All right. Yep. All right. So then what happens after brief intervention? Is we know that there's all these different things going on. This comes from that same another psychoeducation handout about, sometimes it's communicating distress, like I'm really angry, or what is an emotion you might have to do, or talking about values, and maybe they just don't know how to do assertive communication, right? They don't know how to talk about their needs and wants, and they get walked all over, and so then therefore they feel very emotionally dysregulated because no one's listening to them, they're unloved, right? Or maybe it's about how to manage their emotions, and here's a bunch of different things you can do. Mindfulness, thinking traps, finding that missing link. These are all different things. Or yoga, problem solving around distress tolerance. That's my favorite, was when you do the distress tolerance thing where you get a bucket of cold ice water and you have somebody stick their hand in it. They get pretty distressed pretty quickly, and then you're working on those skills, right? Crisis planning, problem solving. These are all different things we can do. These are all different interventions that are out there that are targeting specific suicidal ideation and behaviors. All right. Other things is also there is this thing called the CAMS. I don't know if anybody uses the CAMS here, but this is a 10 to 12 session suicide-specific therapeutic framework, emphasizing 5 core components of collaborative clinical care. It used to be like, okay, we're just going to treat your depression and move on. This is CBT for suicidal ideation, specifically around their 10 to 12 sessions. Dialectical behavior therapy, that's a lot around emotion regulation and distress tolerance. And then CBT, where you're focusing on the suicidal cognitions and behaviors. That's where those are those longer interventions that we don't have time to really talk about today, but we're not just going to prescribe an antidepressant, move on and deal with your depression, right? We want to do these things that really target what's going on. And so we know that when we do these strategies, it's much more effective in terms of reducing suicide risk and suicide behaviors. All right, that concludes my presentation for today. I just want to say thank you for your attention. I know I talked quite a long time, and this presentation is available if you want to use it. You have my permission to do anything you want with it. The only thing is that video from HBO, I have gotten special permission to use that, so you may not I leave it up to you to about decide whether you want to use it or not. But Susan has a copy of my presentation, and I just want people to use the resources in here. I do have some resources for you just to as we're going through. It's in the back of the talk, 988, the crisis text line, 741-741. If you want it in Spanish, you text in a special word. There's the Trevor Project for LGBTQ youth. There's also Lock to Live. This is that pros and cons decisional balance. It's a decisional age, and so it's an online thing that you can access, and it helps you do that decisional balance, and it really actually asks the questions of the client to do it. So it's a wonderful resource. I also want to hit on the Minnesota-specific suicide prevention resources. You guys have a Korean and Chinese helpline, and there's also the Minnesota Department of Public Safety, who provides free gun locks. Wonderful. Again, that's a means to put a barrier and to slow things down. So we have lots of great resources out there around suicide prevention, both locally and nationally, and so please do make yourself available. Yes?
I just want to say that I work for Ramsey County Crisis, and all the counties have a crisis unit like we do. And there's a mobile unit, and then there's walk-in options. It's 24/7.
Yep.
Someone will answer the phone. And there's also some other, helplines like phone lines and stuff like that.
Mm-hmm.
But every county has one of those crisis lines that you can access through your phone.
Yes, that is important. Thank you for that reminder as well. All right, so we are back to saying thank you and turn it over to Susan.
Thank you very much. We ended a little early, so I wonder,
Oh, questions?
are there questions?
Please.
Because there's plenty of Don, and let me get a,
I'll repeat the question while you're getting a microphone.
Yeah.
So Don, what's your question?
My question is this. A number of years ago, when I was working at the Minnesota Lottery, we had someone call in who was contemplating suicide because of their gambling. And in an absolute miracle, the person who happened to answer that call was the volunteer for a suicide.
So that's the hand of God.
Yeah, but my question is, what should we be telling a frontline customer-facing employee at a lottery or at a casino or at a racetrack who stands some kind of admittedly remote chance of finding themselves in that situation?
So the question is for the frontline worker for basically in the gaming industry, lottery, racetrack, casino, and they have a patron endorse suicidal ideation to them. What I would say is, first off, that's more likely to happen than not likely to happen because we know gambling and suicide, unfortunately, overlap significantly. So this to say, this may happen to you, right? And number two is the resources, is helping them to say, like, pull up on your phone or have it, if they have a sheet of the crisis response numbers of that or things like, and just say, I'd want them to say, like, I understand you're in this circumstances. I'm really sorry. I'm not the person who's equipped to deal with this. I'm not trained. I'm not a professional in crisis management, but I know some people who are, and it's just the referral. And you want it to be as much of a, we talk about it as a warm handoff as possible. Depending on the situation, it could be like, please take out your phone, and I'm going to stand here as you call 988. I'm going to stand here next to you while you do that, right? So that's like a warm handoff. You're just kind of ensuring the behavior happens, right? Because unless you're going to spend the time to really train somebody on how to respond to this, it's just about helping them make the referral in a way that it's likely to happen. And just tell them, this is not uncommon, right? If this is not a 1% sort of thing, this unfortunately, we know that people who struggle with gambling problems have this issue. Does that answer? Yeah. Okay, there's a question over here at this table. No, that's you, the one with your hand up. That's you.
It wasn't really a question, but just a comment. I really loved in the video when the interviewer said sports gambling versus sports betting. I think we need to get to that. I think that's a really big problem. People don't see sports betting as gambling, especially young people.
Yeah, young people don't. I'm so fearful for the young
And it's kind of that same terminology when you said we don't say guns, we say firearms. It's
Yeah.
just the terminology.
How we speak and talk is really important. Thank you for highlighting that.
I really like the uns, the three uns. That's so practical and easy to keep in our head.
Yes.
about how to intervene.
Any others?
Thank you, Dr. Jeremy, for the presentation. Amazing. It's just a comment. I just want to add to what she said about the video. I'm a visual person, and I believe if you can find more material on video, clip like this, it stick to my head more than anything. What I want to add is how gambling is so correlated with substance abuse disorder. They say addiction is corny, baffling, and powerful. Just from a mere watch, that is the corny of what that young guy received that led to his death. Thank you.
Yeah, no. We don't know the role that alcohol or other substance use played in that story, in that person's life. But we know that gambling and substance use for some clients really go hand in hand, whether it's in the past, like they had an alcohol use disorder and they're in recovery from that, and then they put that down and they pick up a gambling problem because they haven't dealt with the underlying issues, or the two are co-occurring at the same time. One of my graduate students, she's doing a project right now, she's about to start it, where we're going to look at young adults' sports betting behavior, and we're going to look at, does that change based on basically intoxication? We're going to we're looking at daily stuff and see basically, does their riskiness in their sports betting change based on their co-occurring drinking? Because we hypothesize that when you are drinking, you're also more likely to make more what we call riskier bets based on a couple different metrics we're going to use. So yes. And we don't have a great understanding of that relationship yet, and that's some of the questions we need to ask. Please, over here.
Dr. Omi.
In the back, and then we have one more, and I think that Susan's getting her steps in today.
Yeah, thank you. I really liked your assessment areas and steps. I'm just concerned about cultural implication of those assessment methods. How can you explain more on that area? Because each client has their cultural and spiritual belief.
Yes.
And as such, one assessment may not be enough. How do we diverse our assessment?
Thank you for that question. That is such an important question, that there are so many different communities with different cultural beliefs and backgrounds. Some of it around suicide itself and how that is a shameful behavior, right? But also whether you can even talk about this, right? Or even having thoughts of suicide within certain cultures, that's going to bring shame onto the family, right? So there's all these different, depending on your background. Where I work, I train future clinical psychologists, and we talk about having cultural humility a lot. That's the word that we currently, instead of cultural competence, we think about cultural competence, we do want some of that, but it's more about humility, because you can't be an expert in everybody and everybody's different culture, right? But you can be is curious, and you can be is ask, and then you can also, if you do have that special knowledge, to think about how to tailor what these evidence-based approaches for those different populations, and thinking about those populations, because this may be off-putting, or this may be in some other ways ineffective, and you have to think about how to tailor it. And so thank you for that question. I don't have a great answer beyond that, of just saying either get some expertise or have cultural humility and be curious and ask the client. So.
Thank you for the presentation, Dr. Jeremiah. My question is about the Columbia screening tool.
About what?
Columbia screening tool. I'm familiar with it. I use it, right? I guess my question is, sometimes the patient would do the Columbia twice in a day.
Oh, wow.
And they'll give different answers. So how do you reconcile that? Do you understand? Because I work in a practice where everybody wants to, like the the patient might see me as a therapist and see a psychiatrist, and we both
And they
do
both
the
do the Columbia.
Yeah, and then
So-
the answers are different.
My answer is you're getting somebody who's going like this,
Okay.
right? You're like I showed you on that little graph, right? You're getting somebody who's bouncing, and that's all valid data. And that's when you just say, wow, you're in a very different spot across the day. Tell me what's about your experience. What's happening? Why were you this way at the first time, and why were you that way the second time? And to really try to just to get that understanding. What changed, right? And also to say, I'm concerned about you, right? If it's bopping around. That's a good thought, though. All right. I think there's one last over here, and then I think we're about out of time.
Yeah,
It's
All right. First of all, thank you. We needed this. So you talked a lot about when you're in front of a client, a patient, normalizing that conversation around suicidality so that they become more open to talking about it and stepping into it. My question is, in a broader sense, how do we begin to better normalize the conversation? Because you also talked about the percentage of the population that's not even reporting it.
Mm-hmm.
Like, we only have data on people that are stepping forward and saying, I have a problem, right? How do we even begin to breach and capture that percentage of the population that's not stepping forward? I mean, is there a way? I mean, can we even begin to step into that?
one thing I'll say, so questionnaires are wonderful ways. People are more likely to say yes on a questionnaire than to a person directly, although if you have already have that relationship with somebody and it's a positive relationship, they will tell you, right? So, but there's all the people who are just not connected to the mental health system in any shape or form. And it's that acute event, something's happened, and that's where it's like, oh my goodness, like how do we do this? I think that's where our prevention and a little bit of the public education sort of has to come in. I was sharing last night, I was in Baltimore over the summer for a family vacation. We were going to Camden Yards, and on the way I saw the billboard but put on by the Maryland Council saying 20% of people with gambling problems declare bankruptcy. Right, and it's actually on the way, right next to Camden Yards is a casino. And I said, and it's funny, I told my kids, I'm like, I saw you that stat, I know that stat, right? And my kids are like, thanks, Dad, that's cool, right? They're all like that. But the thing is like, billboards like that or other PSAs, public service announcements, to just say, this is common. Unfortunately, people with gambling problems also experience suicidal ideation. Yeah, I don't know, I'm not a messenger, I don't know the exact messaging, the way to do that, but I think that can be, some of that public education is important. I'd also want to see, and it varies from state to state, is that collaboration with the suicide prevention councils in each state or at the local, county level and things like that, just to do that. There's, I was talking to our neighboring state of Iowa, who's between Missouri and here, and they were really starting to collaborate and partner with the state level 988 line, and they were going to actually ask on their screening, do you gamble regularly or something like that, or they're going to put in the 3-item BBGS in there, just so they could start capturing that data, so they can at least know, and from that data we can start telling the stories, right?
And here we've been trying to get gambling included in the suicide prevention plan that the state is doing.
Yeah.
And so Sonia sits on the task force, the data task force, and
that's great work that you have a voice there.
It took a little time to get there, but that we just continually have to kind of push ourselves into these spaces that don't normally include problem gambling.
And it takes someone who has time, energy, and bandwidth to do it, and money.
Exactly.
So.
Well, thank you so
Thank you.
much. We really appreciate it.